A modern clinical encounter generates an overwhelming volume of multimodal data. Before a physician even enters the exam room, they must synthesize a patient's structured history, clinical symptoms, and a barrage of imaging reports. This grid maps the cardiovascular diagnostic toolkit alone. A clinician must constantly parse 10 distinct modalities to evaluate structural integrity, map electrical circuitry, and assess blood flow under stress. That complexity compounds in spinal pathology, demanding a strict multi-step progression. A diagnosis moves from the physical straight leg raise test to X-rays for bone alignment, to CT scans, and finally to the MRI gold standard, visualizing soft tissue and hydration signals. In this flood of information, clinicians must rapidly distinguish a routine structural failure from a life-threatening emergency. They must separate the sudden hypotension and back pain of a ruptured abdominal aortic aneurysm from the saddle anesthesia and motor weakness defining cauda equina syndrome. Human intuition cannot safely process this density of variables at scale. Gut feeling fails under the data load. Achieving true diagnostic clarity requires processing these inputs through a strict, formal discipline, the mathematics of certainty. To manage this load, healthcare institutions are attempting to deploy artificial intelligence to run these calculations at a population level. But many of these systems rely on the cloud API trap. Sending data to external servers creates unacceptable latency and exposes sensitive patient history to privacy vulnerabilities or unexpected service outages. Sovereign Health Intelligence offers a structural alternative. This architecture pulls the reasoning engine entirely in-house, deploying models on proprietary, localized hardware. The objective is to utilize localized models that are mapped directly to evidence-based clinical probability thresholds. Sovereign AI is the only architecture that protects institutional data sovereignty while enforcing mathematical rigor at scale. Every clinical decision is bounded by a timeline of certainty. At the lower bound is the 20% diagnostic threshold. If probability falls below this line, disease is ruled out and testing stops. At the upper bound is the 80% therapeutic threshold. Crossing this line rules the condition in. We achieve actionable clarity, and further testing only delays life-saving intervention. Between these two markers lies the zone of uncertainty. Here, specific diagnostic testing is mandated to deliberately push the probability toward either the upper or lower threshold. To navigate this zone, clinicians use diagnostic tests as mathematical filters. A test with high sensitivity acts as a coarse filter. It is designed to catch almost every possible instance of a disease. If a highly sensitive test is negative, the clinician can confidently rule the condition out. Specificity is the fine filter. It allows only true, confirmed cases to pass through, excluding the mimics. If a highly specific test is positive, the clinician can confidently rule the condition in. Applying these mathematical filters is the only reliable method for safely pushing a patient out of the uncertainty zone. However, a test's inherent sensitivity and specificity do not exist in a vacuum. Their real-world reliability is dictated by the local prevalence of the disease. In a low prevalence setting of 2.3%, a positive result yields a positive predictive value of only 55%. The result is barely better than a coin flip, lacking sufficient disease signal to distinguish it from a false positive. Take that exact same test into a high prevalence setting of 23%, and the positive predictive value reaches 94%. The result is now highly reliable. To calculate true post-test probability regardless of location, clinicians use likelihood ratios. A high positive likelihood ratio increases probability significantly, independent of where you practice. This reveals why an autonomous AI alert, unaware of local prevalence, is clinically dangerous. In low-prevalence screening environments, AI must be strictly deployed for its negative predictive value. It acts as a coarse filter to rule out pathology safely. AI must function as a contextual diagnostic accelerator, grounded in the statistics of its specific locality. This requirement for strict, predictable logic is why general-purpose, cloud-based large language models fail in high-stakes clinical workflows. Cloud models are prone to model drift. Providers silently push external server updates that alter the AI's underlying reasoning. In a hospital setting, a shifting algorithm breaks validated clinical workflows and fractures critical regulatory compliance cycles. The countermeasure is glass box sovereign architecture. As this comparison shows, we can eliminate latency, data leaks, and model drift by hosting the system entirely on local infrastructure. Crucially, this architecture utilizes safe tensors to deploy frozen parameters. The mathematical weights of the AI are permanently locked. The medical logic is static and reproducible. To run this efficiently, institutions deploy specialized engines. MedGemma 4B operates on a single GPU, optimized for high-throughput, first-pass radiographic triage. For complex reasoning, MedGemma 27B takes over. It synthesizes longitudinal electronic health records and visual data at 1/10 the inference cost of cloud alternatives. Locking these specific model parameters locally is the only technical framework that allows enterprise-scale AI to be legally and clinically trusted. When this sovereign stack is applied to real-world scenarios, the efficiency gains are immediate. We start with the protocol for abdominal aortic aneurysms. Looking at this CT scan and risk map, the AI instantly categorizes rupture danger based on exact aortic diameter measurements. Under 4 centimeters is a 0% rupture risk. At 5 centimeters, risk reaches 15%. The system automatically flags when a patient crosses the therapeutic threshold. For males, a diameter exceeding 5.5 centimeters or rapid expansion of half a centimeter in 6 months mandates immediate surgical referral. Sifting from vascular integrity to spinal pathology, localized AI performs longitudinal analyses on MRIs, comparing current imaging against historical data. In this patient case study, the AI decodes an acute radiological progression. It maps a 2019 baseline showing a minor 3 millimeter disc bulge and contrasts it against a 2023 scan revealing a severe 8 millimeter paracentral extrusion causing canal stenosis. But the protocol enforces a critical caveat. Anatomy does not equal pathology. An 8 millimeter extrusion only warrants surgery if it impacts the patient's functional status. The AI provides the structural insight, but the clinician must correlate it. In neurogenic claudication caused by spinal stenosis, the pain is triggered by standing. Conversely, it is relieved by sitting. If those mechanical triggers are absent, the clinician must look beyond the diagnostic image. The AI engine maps the structural failure with high velocity, but crossing the therapeutic threshold relies strictly on a human validating the functional symptoms. This brings us to the clinical mandate that governs all data analysis in the sovereign network. Treat the patient, not the image. Diagnostics require holistic surveillance. The physician's responsibility extends beyond the patient's primary complaint to encompass their entire risk profile. Look at this report. While analyzing a spinal CT for lower back pain, the AI scans for silent threats hidden within the data, successfully flagging a lung RADS1 finding. This ensures cardiovascular and pulmonary tracking happens concurrently, even while treating an acute spinal issue. Localized AI surfaces systemic risks that might otherwise be missed during specialized care, acting as a holistic failsafe for the clinician. Integrating mathematical probability with localized AI provides a definitive increase in the speed of clinical triage. It operates on the philosophy of non-replacive AI. The system processes the data flood, applies filters, and drafts a preliminary report. It's a drafting tool, not a decision maker. Crossing the therapeutic threshold to initiate treatment always requires the evidence-based judgment of a human clinician. To make the system viable, institutions must own their AI weights. They must pull their data out of the cloud and lock their parameters locally to secure their operational future. The sovereign standard provides the infrastructure to transform clinical ambiguity into mathematically grounded decisions.